Welcome back to The Explainer. Today, we're throwing on a detective coats because, let's be honest, reading clinical research isn't just about passively absorbing facts. It's an active, thrilling investigation. Every single time you look at a study, you aren't just reading, you're hunting. You're searching for statistical saboteurs, those errors, biases, and illusions that are constantly trying to pull you away from the actual biological truth. Our job today is to crack the case.
Here's the roadmap for our investigation today. We've got 4 steps: setting up the investigation, spotting the biases, confounders versus effect modifiers, and decoding the data. Breaking these complex biostatistical concepts down into these specific steps is going to make them instantly recognizable for you, especially when you're under that intense board exam pressure.
All right, Section 1, setting up the investigation, establishing the scene.
Okay, so before we can evaluate any evidence, we have to know exactly what kind of scene we're walking into. The fundamental divide in all clinical research really comes down to one simple question: are we just watching or are we intervening? In observational studies, we simply observe associations without doing any intervening. We're just recording what naturally happens. Experimental studies, on the other hand, like your randomized controlled trials, actively assign treatments. Now, you might be wondering, why don't we always just do experimental trials to prove causality? Well, because we can't exactly randomize patients to, say, smoke a pack a day or breathe in asbestos just to see what happens. It's totally unethical. And that is exactly why observational studies exist.
When you're evaluating those observational studies, time is literally your best orienting tool. A cross-sectional study? That's a present-day snapshot. It looks at the exposure and the outcome at the exact same moment to give us a prevalence. A prospective study grabs a group of patients right now, today, and follows them forward into the future to see what develops. A retrospective study, though, stands in the present and looks backward in time, usually digging through medical records to piece the whole story together.
Now, within those timeframes, we have 2 highly tested designs that you absolutely must keep separate: case control and cohort studies. A case control study starts with the outcome. So say you gather patients who already have lung cancer, and then it looks backwards for the exposure, relying on odds ratios. A cohort study does the exact opposite. It starts with the exposure. You gather a cohort of smokers, and you follow them over time to see if they develop the outcome. Cohorts are what allow us to determine relative risk.
Moving right along to Section 2, spotting the biases, the usual suspects.
Now that we know our scene, we need to identify the culprits trying to systematically sabotage our truth. Let's test your detective skills with a multi-center study scenario straight from our sources. Say researchers aim to determine if a novel antihypertensive medication increases the risk of acute kidney injury. They recruit 500 patients currently taking the medication from a specialized tertiary care nephrology clinic, and they get 500 controls from a general community wellness center. Over a 2-year period, the researchers find a significantly higher rate of kidney injury in the drug group. So, what's the critical flaw here?
Did you catch it? This study is heavily compromised by selection bias, specifically Berkson bias. By selecting the exposed patients from a specialized hospital clinic rather than the general population from which the controls were drawn, the researchers enrolled individuals who were systematically sicker. They possessed a much higher baseline risk of renal pathology right from the start. You just can't compare a specialized nephrology cohort to a healthy wellness cohort. Doing so permanently breaks the internal validity of the trial.
Let's look at another common trap. Imagine a mother is asked to remember her specific vitamin use during her pregnancy, but she's only asked this after her child is diagnosed with a rare condition. What error is lurking in this retrospective setup?
Yup, you guessed it, recall bias. This is the classic vulnerability of case control studies. Parents affected by a severe condition are highly motivated to find a cause, meaning they're going to intensely search their memories and over-report past exposures. That's a stark contrast to healthy controls who simply haven't spent months agonizing over what went wrong.
And here's a quick rundown of the rest of our suspect lineup. The Hawthorne effect is when patients magically start eating healthier simply because they know a researcher is watching them. Observer bias is when the investigator's own hopes subconsciously alter the data, which, by the way, is exactly why we use double blinding. Attrition bias happens when unequal dropouts totally skew the final pool. And lead time bias? That is the illusion of prolonged survival just because a fancy new screening test caught the disease earlier, even though the actual time of death never changed.
Which brings us to Section 3, confounders versus effect modifiers, innocent bystanders versus accomplices.
Okay, this is the absolute climax of our investigation. We have to learn to separate statistical illusions from biological realities. Let's look at this specific study design. An investigator designs a retrospective study to evaluate whether a high intake of processed sugar is associated with the development of early-onset colorectal cancer. The crude analysis shows a strong positive association with an apparent risk ratio of 2.5. Wow! It looks like a clear, direct causal link, right? But is it?
To really find out, the investigator uses a strict visual screening rule. They stratify the data. The investigator stratifies the study population into two distinct subgroups based on the presence of chronic physical inactivity. And look what happens. The association disappears entirely. Among the physically inactive individuals, the risk ratio drops to 1.0, and among the highly active individuals, the risk ratio also drops to 1.0.
This outcome demonstrates the absolute classic signature of confounding. See, physical inactivity is heavily associated with a high-sugar diet, and it independently acts as an independent risk factor for colorectal cancer. It's essentially creating a false statistical illusion of direct causality in the overall unstratified data pool. The sugar wasn't the sole driving factor. The confounding variable was in the background pulling all the strings.
Now, to master these distinctions under board pressure, clinicians must use that strict visual screening rule when evaluating stratified metrics. So let's pivot to a contrasting scenario. Imagine a trial investigating whether a new immunomodulator medication causes pulmonary fibrosis. The overall crude odds ratio is recorded as 3.0. What happens to the data when we stratify the patients by their tobacco smoking status?
Well, check this out. When stratified, the odds ratio among heavy smokers spikes all the way up to 5.5. Meanwhile, the odds ratio among lifelong non-smokers completely drops to 1.0.
Because the risk values in the two subgroups are radically different from each other, this demonstrates effect modification rather than confounding. The underlying cellular damage caused by tobacco smoke actually interacts biologically with the medication. It's modifying its clinical effect and concentrating the pathology entirely within one specific patient subpopulation. Effect modification is a biological reality you absolutely want to report, whereas confounding is a statistical illusion you want to remove.
Finally, Section 4, Decoding the Data, the Hard Evidence.
Let's see how all of this builds into evaluating the actual hard numbers in a study. When you're looking at relative risk or odds ratios, the number 1.0 is essentially the center of the universe. A value of exactly 1.0 means there is absolutely no association between the exposure and the outcome. Crucially, if a study gives you a 95% confidence interval, that interval must not cross 1.0. Like, if your confidence interval is 0.9 to 1.5, it includes 1.0, which means your results are totally not statistically significant.
And, alongside those confidence intervals, we rely heavily on the p-value. A p-value of less than 0.05 simply means there is less than a 5% probability that the results of your investigation were due to random chance alone. It's the standard metric that tells us our findings are statistically significant enough to trust.
But how do researchers actually arrive at those p-values? Well, by using the right statistical test for the job. Think of this matrix as your ultimate cheat sheet. If you're comparing continuous data, like blood pressure, across 3 or more groups, you use ANOVA. If you're dealing purely with categorical data, like comparing active versus sedentary against hypertensive versus normal, you use a chi-square test. And if you're just comparing continuous data between 2 independent groups, you stick with the classic t-test.
All right, this brings us full circle. As you can see, the core of any reliable clinical study is maintaining a clean, direct line between the exposure and the outcome. Confounding variables are always going to try to create false triangles of association, and biases are going to try to warp the true lines of reality. Your job as a clinician is to cut through all that noise. So, we're going to close our investigation today with a challenge for you. With your detective toolkit now fully equipped to spot Berkson bias hiding in specialized clinics, to unmask confounders hiding in unstratified data, and to identify real biological effect modifiers, how are you going to scrutinize the next clinical trial that crosses your desk? Remember, don't just read the conclusion, investigate the design. Thanks for hanging out with me for this explainer, and keep questioning the data.